welcome to today's episode of gIDE Unlocked. This is Sascha Jovanovic, and I'm here today with my colleague and friend Chen from Australia. I'm kind of lucky today because I'm here in Melbourne, Australia, at a conference here which is organized by Straumann, and I feel always lucky to be here in Australia. Like, this is your hometown, right? Melbourne.
Yes, it is my hometown.
Yeah.
Lived here for over 35 years.
Wow.
Yeah.
I know Melbourne is famous for many, many things. Let's say we can not talk about dentistry right away, but like, what is Melbourne like? So for us who are listening to this podcast, what is Melbourne really famous for?
I think Melbourne is most definitely the sporting capital of the country.
Oh, wow.
We have the tennis open.
Yeah.
We have the Grand Prix. We have 3 or 4 different football codes that are being played all the time. So, and Melburnians love the outdoors and outdoor activities.
Uh-huh.
We have great parklands. It's probably also, I think, one of the more European of the cities. We've still got trams and we've still got bicycles. So it's really nice. Nice place to live.
And I know, of course, you're famous for your coffee culture.
Yes.
So that's like, the first thing I do when I get to Australia, I got to have a flat white.
Yes, yes.
So yeah, beautiful here. I'm always excited to come to Australia. Like, I spent a lot of time in Sydney. I like Melbourne a lot. Perth, I don't get it to enough. And then there's all this vast land that you have. So
yes.
I need to visit that more, I think.
Yes, and you were telling me you've been able to do a hit out on Rod Laver Arena.
Yep, I was lucky. I can
tell you, not many people get to do this.
Yeah.
So you must be a very important person.
No, I think the AO is probably very close to my heart, and it's probably one of the happiest slams out there. And so for me to go there, it's special. So let's focus on dentistry. Now, Stephen, I know that you've been involved with dentistry here in Australia for a long time. And tell us a little bit about the evolution that you've seen with implant dentistry. Do you think it's different than what we have in the US or different than in Europe? How has it moved from specialty towards general practitioners? How does that work?
Look, I think it's probably happened in a similar way. Implant dentistry came here through Bronnemark and Nobel Biocare in the mid-1980s, centers in Sydney and in Perth. And very much at that time, the focus was on fully edentulous patients, providing them with solutions to change their lives. Very controlled in the sense that this was only delivered through specialists, maxillofacial surgeons and prosthodontists. So they had good control, quality assurance, I think, over the treatment protocols and the training of specialists, and therefore, the outcomes for patients. That probably lasted for about a decade to 15 years, and then gradually it moved into partially edentulous cases. And then, as you know, more and more implant companies on the horizon coming in and competing for market share, and there was a gradual but inevitable shift towards implants being done more and more within the general practitioner community, which there's nothing wrong with that, of course. But unfortunately, there didn't come with that the level of training and the level of expectation of standards from the implant companies, nor from the individuals themselves. So we see, if we fast forward 3 decades down the track, implants are being done in rather large numbers. Of course, we've got a small population, but we are starting to see more and more complications. It's a numbers game, Sascha.
Yeah.
If you have 5% complications and you see 100 patients, it's only 5 patients.
Right. But I always wonder, but I always wonder, we just got Danny, you can just come here for a second.
Come in, Danny.
We just got
a cameo
interrupted
appearance
by a dignitary, so we just have to say hello to him. Good to see you. You can look at the camera there.
There's the camera?
Yeah. So this is Professor Danny Boozer right here. Welcome, into our, if anybody can interrupt us, it's you. So no problem.
Okay.
But we're just talking about the transition from specialty towards general practitioners. Now, I'm thinking sometimes about were the early days of implant surgery and implant restorative, did we make it too strict, or are we making it now too loose? Because if you think about it, like in the old days, an oral surgeon had to have like obviously like 3 or 4 years of postgraduate training. A prosthodontist had to have like at least 2 or 3 years, and then they had to have the implant training. So the question is like, was that what we needed? Or is it now that like, we're just making it too easy, that people can enter the market with like a weekend course, and then they're getting some free implants and just go for it? So what do you think, Danny?
I believe that the dentists should start to regulate the market, because that's the only field in medical health science field that you can do surgeries without the proof that you have learned to do it. Because at University of Bern, when I got the chair position, we decided, and that was then in all Switzerland adopted, that it's complete stupidness to do 1 or 2 procedures to remove a very easy wisdom tooth as an undergrad student and then say we do a practical education. We stopped the nonsense and said they assist, and those who want to learn how to do surgeries, they go to a postdoc program.
Mm-hmm.
And because in orthopedics, eye surgery, everywhere you have to be a specialist to do these procedures, and it's not regulated in the field of dentistry, and that's not good for the reputation of our field. So I think we should somehow say, if you take a knife into your hands, you should be educated in that field, perio, oral surgery, max fax, whatever you see. But that will be difficult to impose, because the dental associations are dominated by GPs, and they think we take something away from them. Mm-hmm. But in a way, we should do it.
What about in Australia? Do you see that as an opportunity?
It's a very similar situation, Danny. Mm-hmm. There is no requirement for any form of accreditation to perform dental implant procedures. But there is none for molar endodontics. There's none for doing orthodontics.
Yeah. You know why it is? You know why it is? See, in the medical field, it's regulated because it's paid by insurances, and we have fee for service. That means 92% of all dental treatments are paid by the patients themselves. So there's not a strong guy like insurance companies who control who is doing what. Mm-hmm. You see? Mm-hmm. And
but there are some countries, not many, that have started to impose restrictions on.
In the Netherlands, they have.
Correct, Netherlands, and in the Middle East as well.
Middle East as well, yeah.
And sometimes I think maybe that external regulation is required to try and rein this in, but then there needs to be a political will to do this.
Mm-hmm.
You have to protect the patients.
Ultimately, it's for the patient's protection.
Absolutely, you have to protect the patients.
So let's think about for a second. Like, if let's say I train a lot of practitioners. Like, many are specialists, many are general practitioners. I think the one thing that I see, first of all, that the general dentist or specialist who has a drive to want to learn and has a passion to get better are really those who can really thrive in this implant dentistry. But those who are just in it for doing a quick job and placing an implant to add some cost to their practice, that's not sufficient.
No, and I think this is it. It's not so much specialist generalist, it's the individual. If you have the mindset that you're prepared to go through a program of learning, sequential learning, and gradually increase your experience, don't extend the treatment beyond what your capabilities are. Recognize and understand what your limitations are so you don't exceed your own boundaries. Put the time, the effort, and the expense into the education that you need. Of course, you can ultimately succeed in what you do, and you become a good implant surgeon and a good implantologist. But those individuals are, they're a complete minority compared to the vast majority who think that they can do a 2-day course at a hotel somewhere and then go home and place implants.
Okay, so we agree on that.
So,
I mean, basically university-based, right? Daniel, if we have a general practitioner who wants to learn about implants, is there like an hour that you say, okay, they need to learn like, let's say, 100 hours or 300 hours just to get more the fundamentals and the basics? Is there something that we can give them?
I think so. You see, I don't think that you must do a 3 or 4 year program in a postdoc university setup, because that might be then too limited. But for example, the Swiss Implant Society is having a 2-year program, and this is actually excellent. It has multiple modules, including also then, of course, the practical sessions, whatever. And I think these programs would have to be, I don't know, checked by an authority and said, yes, if you get this title, then you can do it.
Yeah, but at the ITI, we have our foundation, intermediary, and advanced level training courses that the aim is to bring someone through the learning journey in a sequential way until they get to the point where they can do then more.
Basically progressive learning.
Progressive learning.
Not like aggressive learning in a weekend, but progressive learning.
But you see, not everyone wants to put their time into this. You know,
well, I think it's important that all three of us probably like agree that there's a problem, and let's shift it. You know, there's obviously at this moment there's kind of this cloud of fear for peri-implant complications, which we call peri-implantitis. And I've been involved with peri-implantitis now for 35 years, like researching it early on in the 90s. And then early on, we really thought about that this is more coming from like, maybe some local conditions, maybe some mechanical conditions, etc., surface conditions. But today, it's shifting again a little bit, right? So is this also in Australia that you see like a lot of problems with peri-implantitis?
Yes, most certainly. I mean, can I take a step back?
Right.
I want to say something about peri-implantitis.
Okay.
We treat peri-implantitis as a disease.
Mm-hmm.
It is not a disease. A disease is of natural structures. This is a man-made disease, if you like, because it's a metal screw that's gone into the bone, coming through the epithelial barrier. Mm-hmm. If you look at our orthopedic colleagues, they don't have a disease for peri-prosthetic joint infections. What is it called? It's called an infection.
Right.
And what is it deemed? It's deemed a complication. They either have peri-surgical complications or post-operative early and late complications. Mm-hmm. Bone-anchored hearing aids are the closest we can get. They don't talk about peri-bone-anchored implantitis. You see, so we've looked at it as a disease. Now, looking at it as a disease has allowed us to forensically examine all the risk factors, systematic reviews, risk factors, so we know all of this. Fantastic. But when you do that, you assign the cause to the patient. Mm-hmm. If you regard it as a complication, then a significant amount of that then has to be turned towards the operator and the clinician. Right. We have to change the way we look at this and no longer treat it like a disease and treat it as a complication of treatment. Mm-hmm. And then the focus will turn back on the practitioners to manage this. So that's the first thing.
No, I mean, I think it's so important to say that, because like obviously there's a certain percentage that we can say maybe has local conditions, maybe like it's an immune system problem, maybe it's a medical history of the patient, but like in a large extent.
You put an implant into a diabetic patient, uncontrolled diabetes, or you put an implant into a patient with uncontrolled periodontitis and you don't follow them up. You have made the decision to do that.
Right.
You're in the driving seat. It is still a man-made disease.
Definition,
right?
Yeah. The circle is larger.
Yes.
It's site-specific. Because when we, and I will show that in the lecture, you see when you analyze the prevalence of peri-implantitis per patient or per implant, it's much higher per patient. And that means you can have 6 implants and one of them is diseased, you could say. That means that shows it's not actually the general condition of the patient, it's the local factor that turn one implant into an infected one. And that's very simple, and it's true. I think that the majority of these complications are man-made, yes.
Yeah, I fully agree.
So then, let's say man-made, that means basically like we are causing the complication partially.
Surgical and prosthetic
And is it?
errors.
Yeah. So we have surgery, we have restorative, and of course we have lab work.
Lab work, yep.
So where do you see? Do you think it's evenly spread out, or like do you see like more problems with one area of discipline?
I think it's the surgical is
yes.
probably the main one, compounded by poor restorative design, and often the restorative management and the design of the prosthesis is abrogated to the laboratory to do.
Yeah.
And guess what most lab technicians do today? They never see a patient. Everything's done on computers. So they produce these wonderful 3D designs, and then they get milled and are completely uncleanable when you put them into the patient's mouth. Right?
Yeah,
And so
there was a very interesting moment, like when I was at UCLA, we had a very famous abutment called the UCLA abutment.
Yes,
we
of
remember
course.
it.
And you remember that. That was like in the, let's say, early 90s, a lot of research. Research came out because, it was aesthetically driven, right? We had like California, Southern California, everybody wanted aesthetics.
Through the incisal
And
edge.
we couldn't do titanium abutments on them because titanium abutments, the lowest was 3 millimeters or 4.
Yeah.
So guess what? When the research came out, there was not a single prosthesis which was fitting. 100% was ill-fitting.
Okay.
And that connection between the abutment and the implant, which of course was a Brannemark implant at that time, was bone level, caused infection. And so we had a tremendous amount of like bone loss, not in the good cases, right? There were some prosthodontists and some laboratory technicians who did an amazing job. But of course, then they went to the general market and it was very difficult to control.
Sascha, also they were cemented. Many of the crowns were cemented.
Yeah. So then we had the cement. So, Danny, what do you think now? Like, when we think about this as man-made, maybe, like, what can we say? Because we're all concerned about the future of implant dentistry.
Yes, absolutely.
I know you have an idea about this here. Like, what can we say to the clinician who's listening about what to do to control, the quality of care and to control, like, the longevity of implants? Because, like, you've had patients who are 30, 40 years. You have had patients 30, 40 years. I've had patients 30, 40 years. But I doubt that many of the clinicians who are doing this quickly are going to have that kind of success.
Of course.
So how can we bring them to this side, to the 30 to 40 year side?
I think we should try to get universities, associations, but also the companies together to develop together a strategy. And the biggest or the most important question is, when we take all dentists, you see the pool of dentists, what's the percentage of all dentists who should perform surgical procedures? Is this 15%, 20%, 30%? And they should take care of the population. Because I give you the numbers in Switzerland. We have 7,000 dentists and we have 80,000 implants placed. If every dentist places an implant, then it's roughly 10. And we all know that's not enough to really build up experience, whatever. If it's 50%, it's double. If we go for 20%, then actually gets into the good numbers, 50 plus. And I think that's one point. The second point, that's what I see in Switzerland, the trend goes clearly towards group practices, because 70% of our dentists are females, and they work 40%, 60%, what I see now. So they go all into group practice, 5, 6 dentists together. And then one of them should be surgically top trained and takes care of the whole group. And then you bring the numbers up. If one out of 5 is a surgeon, then it's 20%. So I think we should move into this direction to influence the market and tell them, look, not everybody has to place implants, not everybody is doing orthodontics or perio, but at least one of the group should be top educated and experienced. And that will improve.
Yeah. Any last words of wisdom from your side, Stephen?
We're sitting in a conference today, and we have the audience who I refer to as the captive audience. These are the individuals who want to learn.
Yeah.
Our problem is capturing the vast majority out there who are doing implants. How do we get this message across to them? That's, for me, the biggest issue.
Yeah. Well, I think like the most important thing is like, so everybody who is concerned with dental health is a healthcare provider. And a healthcare provider needs to understand that the responsibility is to take good care of their patients.
Yes.
We're not here to give an implant just like for the short term. An implant is like a long-term solution, sometimes a permanent solution. So let's look at that. So I appreciate it. Danny, especially you just joining us. This was a one-on-one, but then it became a three of us. So hopefully...
if we're going to be gate crashed, who better than
Danny?
Danny.
So this was a really good session of the Unlocked podcast, and I'm looking forward to our next visit. Come visit us in California.
I will do that.
Okay, thank you.
Yeah, we'll do that for sure, yes. But first you come to Bern. And we go to Firenze.